Dear friends and colleagues, as president of the World Society of Arrhythmias, I want to welcome everybody. I want to thank all the speakers of this webinar, and I want to pass the mic to Tom Deering, our person in charge of the educational board, who is going to start announcing all the details of this important meeting. Dear Tom, go ahead, please.
Thank you very much, Oscar. We're very happy to be hosting this educational program today. We thank all of you who are joining us live or will join us later remotely. Many times in medicine and cardiovascular medicine particularly, there's clear-cut answers on what we should do in relation to particular clinical issues. Sometimes, however, there's great controversy. And the concept behind these sessions are to have a debate on areas where there is controversy. So it's my great honor to chair this or co-chair this session with Yan Yao, who's a well-known electrophysiologist at Fuwei Hospital in Beijing, China. And we have two renowned international experts in the field of electrophysiology, Dr. Andrea Russo, who is a professor of medicine at Cooper University, Rowan University in New Jersey, and a former past president of the Heart Rhythm Society. And we have Jeff Healey, who is a professor of medicine at McMaster University in Canada. So we're going to have two cases we will discuss today. I will hand it over to you, Jan, and you can lead us through a discussion on the first case. Thank you.
Okay, thank you. Nice to everyone. Greeting from China. Today, the first case will be presented by Dr. Russo from Cooper Hospital. Who is also the former president of HRS. And Dr. Russo, please.
Great. Thank you so much. It's a pleasure and an honor to be here. I thank the course organizers and the chairs for inviting me to this, really interesting sessions with some great topics. So the first case is a 57-year-old with heart failure and reduced ejection fraction, EF of 33% on guideline-directed medical therapy who has a primary prevention, ICD, and asymptomatic AFib with adequate rate control, has an AFib burden of about 13% detected on the device. And I'm going to tell you why we should recommend a rhythm control approach. And this rhythm control approach should be early. Here are my disclosures. I'm going to highlight the patient's age is young, EF is low, and the question is does it matter if he's symptomatic or not? So as some background, we know that AFib and heart failure often coexist. AFib promotes heart failure and vice versa. There are rapid rates and irregular rates and loss of atrial contraction. You can induce left ventricular remodeling and atrial remodeling, and all of this can have adverse clinical consequences. We do know that AFib and heart failure, when they coexist, there is an associated adverse effect of the presence of AFib on heart failure in terms of mortality. And this holds true for both patients with preserved EF as well as impaired LV function. There are 4 pillars of AFib care, one of which is rhythm control. We can use antiarrhythmic drugs, and we select the drugs based on underlying heart disease or other comorbidities. But unfortunately, if you have heart failure, you have very limited drug options, and ablation is often an option we consider. So Dr. Healey will probably tell us about studies that were dating back to the early 2000s, including AFFIRM, where this study looked at patients who were age 65 or older and randomized patients to rhythm control versus rate control. It should be noted that anticoagulation was encouraged in the rhythm control group, but they were allowed to stop it if they were in sinus rhythm for 4 weeks or more. Overall, the rhythm control strategy, as you can see here, did not have any survival advantage over the rate control strategy. Things to note in this study is that heart failure was present in about 23%. You see the overall EF was not very low. And there was a lower use of beta blocker in the rhythm control group. And they used class 1A drugs, which we never use now, right? And that was in 20% of these patients. In an additional analysis on the on-treatment analysis, different variables were associated with a lower risk of death. In addition to the presence of sinus rhythm, the ability to maintain sinus rhythm had a better outcome in those patients, as well as use of anticoagulation, which was warfarin at the time. So we know that why these results look like this? Well, we know that rhythm control therapy in that trial, as well as in other trials, was really not very efficacious with these antiarrhythmic drugs, not very good with maintaining sinus rhythm overall. There are side effects of drugs, and patients may be non-adherent. Pro-arrhythmic responses may play a role. And then also, we didn't pay attention back then to whether or not we're treating people early, and they may have had really extensive atrial remodeling to the point where we can get a lot of disease in the atrium. We want to get patients earlier when they're paroxysmal before they become more persistent and get scarring in the atrium. Here's an MRI scan or an electroanatomic map. So this is really a newer paradigm. So a more contemporary study we should be looking at is East AFib-Net. And this study looked at patients with early onset AFib, early defined as less than or equal to 1 year. This was multinational study, and actually patients were really early and on a median of just 36 days. It should be noted that stable heart failure was present in about 28% of this group, and they were randomized to rhythm control, shown here. Most of these were rhythm control with antiarrhythmic drugs, just 8% up front, a little bit more, 19% during the 2-year follow-up, and compared to usual care. Overall, this is the primary outcome measure of a composite outcome of death from cardiovascular causes, stroke, hospitalization with worsening heart failure, or acute coronary syndrome. You could see here a significant benefit of early rhythm control compared to usual care. And so early rhythm control was associated with a lower risk of these adverse cardiovascular outcomes. And also to note is that sinus rhythm was present in more patients, 82% in the early rhythm control group compared to just 60% in the usual care group. Other comparisons to AFFIRM, you can see here oral anticoagulation discontinuation was much higher in AFFIRM than it is in East AFib-Net. Ablation was really not used very often at all, much more often used during follow-up in East AFib-Net. So really we've had progression of rhythm control therapies over time. So these studies, including AFFIRM, really aren't relevant to our studies in our population now and our care. So what about heart failure in East AFib-Net? The subgroup analysis with heart failure still also had similar benefit. Rhythm control therapy was better in terms of the primary outcome in the heart failure patients, whether you had reduced EF or other emitter or preserved EF. Did it matter if you were symptomatic or not? And the answer is no. It doesn't matter if the patient feels the AF or not. So our patient was asymptomatic. Now, CASTLE-AF looked at a little different population. You could see here, low EF. These patients had ICDs and randomized ablation for rhythm control versus medical therapy for AF, which could be with rate or rhythm control. And you can see here, a dramatic improvement in the primary outcome here in those with death or hospitalization for worsening heart failure. Those who received ablation for rhythm control compared to medical therapy did much better during follow-up. Cabana, if you look overall the trial, the intention to treat analysis in comparing drug therapy versus catheter ablation was not significant in the overall trial. But if you just look at the heart failure patients here, 15% of these trial participants had a history of heart failure. You can see the dramatic impact of ablation in this group. Not only did it improve the primary outcome in the intention to treat analysis in the heart failure patients, it also resulted in a reduction in mortality as well as a reduction in the freedom from AFib recurrence. If you look at a pooled analysis of randomized data in patients with AFib and heart failure, you can see that compared with medical rate control, rhythm control with drugs was associated with a similar outcome in terms of mortality. However, compared to medical therapy, rhythm control with ablation here in the pooled analysis resulted in a significantly lower all-cause mortality. What about age? Our patient was young, less than 60 years old. You could see that in the Cabana trial, when we looked at this, the largest relative and absolute benefits of ablation was seen in the younger patients. So in our patient, young patient, low EF, even though the patient doesn't have symptoms, we would definitely recommend rhythm control. And these antiarrhythmic drugs in the past were different than what we're using now. And now it was underutilization of anticoagulation in earlier studies. More recent trials do show the benefit of rhythm control, particularly with ablation in the heart failure population. And I would say not only should we use rhythm control, but it should be administered early to improve outcomes. Thank you.
Thank you very much, Dr. Russo, for this wonderful case and the presentations. Now it's time for rebuttal. Anyone? Okay.
Yeah, thank you very much. So excellent presentation. I agree, Andrea, very nicely done. But I am going to present here a different point of view. So we'll talk about this case, rhythm control in an asymptomatic individual with subclinical atrial fibrillation. And I'm going to argue not so fast. And I'll step us back to medical school when we started. And why do we do anything in medicine? We basically do two things. We treat people to reduce people's symptoms or to improve their outcomes, including survival. And, for the first here, this is completely off the table because this is an asymptomatic individual. So clearly we can't make someone who's asymptomatic less symptomatic. So really what we have to focus on for this debate is, do we really believe in this patient with very short burden subclinical atrial fibrillation? Can we improve their outcome through rhythm control? And Andrew's right. I did dig up the old AFFIRM trial just to show here there was no effect on the primary outcome, including things like stroke and death and major bleeding. It's interesting in retrospect, even with very clever people like George Wise, we didn't really focus on heart failure back in the day. That's only 20 years ago. So that's an interesting thing we might have forgotten. It's not even on the table. But really did not move the needle at all with rhythm-based control using antiarrhythmic drugs. And yes, we've had some innovation here with the AFNet #4, the EAST trial. And just to break it down, I want to focus on a few things here. So first of all, about 26% of people, 27% of people in this trial had persistent atrial fibrillation. Now, all these individuals had AF diagnosed within the previous year, but you can see about a quarter in atrial fibrillation in a persistent form, about a third with paroxysmal, and a third first onset. But these are patients with arguably a much higher burden of atrial fibrillation than we're talking about with the case presented in front of us. And yes, some of them were asymptomatic, about a third again, but 40% had come to a cardioversion in the past. So again, the burden, the duration, frequency of episodes, I would argue here is much higher. And burden does matter when it comes to stroke and also when it comes to heart failure. And as we know from the treatment results with EAST, there was a 20% relative reduction in their primary outcome, which is modest, right? 20% is a modest effect. It's definitely better than the AFFIRM days, but it's a modest effect. But just focus your eye on this. This is a 1.1% per year reduction in that composite outcome, including things like stroke. So 1.1% reduction. On the other hand, we did see an excess of severe adverse events. And if you draw your eye to the third row here, serious adverse events of special interest related to rhythm control therapy, we see a 3.5% increase in these severe adverse events. And these were things like torsade de pointe, pericardial tamponade, major bleeding related to ablation, and hospitalizations with atrial fibrillation. So a mixed bag of different effects, but some of which were considered serious. So you're weighing now a 3.5% increase in these bad things happening versus a 1.1% reduction in important things on the benefit side. And all along, you're doing this in a patient who's not actually complaining to you of this problem. So, and I'd argue we should have a high bar when it comes to intervening on asymptomatic individuals. Now, the other piece of this, as I've alluded to, we've seen this on the stroke side here, data from Brian Gage in orange, data from our ASSERT trial in blue and white. And you can see when you're dealing with this low burden subclinical atrial fibrillation here, looking at a stroke outcome, the absolute risk here is lower. So going, for example, with CHAD score of 2, from a 4% per year annual risk with clinical AFib to just over 1% per year with subclinical atrial fibrillation. So there is this dose effect. The more AFib you have, the more risk you have. And so that 1.1% reduction in the EAST trial, it's unclear to me whether that's actually what we might expect with rhythm control or actually expect something a lot smaller. So I think overall, I would conclude here that there's no possible way we can improve this patient's symptoms, so that reason to engage in rhythm control is off the table. When it comes to improving outcomes, yes, there may be some tantalizing evidence from newer clinical trials like EAST, like heart failure trials, including CASTLE-AF, but these trials really did not enroll patients like the one in front of us. These type of patients with subclinical infrequent atrial fibrillation tend to have lower risk than patients in the trials that have been done. And even let's assume the best case scenario for Andrea here, that we could get a 1% reduction in clinical events if we controlled the rhythm, then we still have to do the discussion with an asymptomatic patient whether they'll accept a 3.5% increase in the risk of major adverse events. So I'll stop there and go to rebuttals.
Great.
Thank you. Thank you very much, Dr. Healey. Anyone? Dr. Russo?
No, I actually agree with, Jeff. I think the do no harm part of this is an important part. And so I agree with that, and obviously deliberately didn't show the adverse effects in my presentation. But, I think, the data has evolved, and even our guidelines, we're looking at recommendation for rhythm control, and you bring up the adverse effects, most of which were associated with antiarrhythmic drugs and with catheter ablation. We do know that in experienced centers with high volume, the adverse event is much lower. So even in 2019, the US guidelines are currently being updated and would be hopefully ready in a couple of months now. But even back then, in those patients, the data was interpreted by the guideline group that a catheter ablation may be reasonable in these patients with heart failure and reduced EF. And then the more updated, this is actually not correct, the reference on here is the more recent updated 2020 here, guidelines in the European guidelines state that you can consider it as first-line therapy for rhythm control in patients who have heart failure and thought to have a tachycardia-induced cardiomyopathy, because you could reverse the tachycardia-induced cardiomyopathy independent of symptoms. So their symptom might be heart failure and independent of symptoms of feeling the AFib, and that AFib ablation should be considered in selected patients with a low EF, and that was given a 2A. So even the guideline group felt that. I would say it's not just should we control rhythm, but how we control it is important, but is how early to go. So EAST AFib net looked at within 1 year. This is a study, a collaboration, Change AF, between the American Heart Association and Duke, looking at patients randomizing with just after the first detected episode of AFib. Can we get those kind of results in EAST AFib that we might be able to even improve outcomes in those individuals? Thank you.
Yeah, no, I won't show any slides for my rebuttal. I think it's, I'm never going to argue against doing good clinical trials, and I applaud the Duke group for moving forward with that. And, I believe we also have moved the needle on rhythm control over the years, as you had highlighted, by understanding that did not obviate the need for anticoagulation. Still, when you look at the EAST data, yes, there was a small reduction in stroke. But I don't think that's the whole story of going from, very low use of anticoagulation to over 80% use. So, there are other factors here. There is some play of chance. There are some secular trends in blood pressure reduction and other interventions. Again, I think the crux of this discussion here is around burden and when. Clearly, when you've got a symptomatic patient, there's many good reasons for intervening. If you believe there's a tachymyopathy, if that's the etiology of LV dysfunction, which I don't think is applicable here with someone who's having such infrequent atrial arrhythmias, then I think that's, again, a different discussion. But I think when you're dealing with very infrequent asymptomatic arrhythmias picked up with long-term monitoring, I think there you have a tougher sell, you have a higher bar. And ultimately, this will come down to a threshold. How much atrial fibrillation does it require? This is the same debate we're having with stroke prevention, and which we'll have some resolution to this year with our 2 large clinical trials globally going to be presented. But I think here, for me, this is still a high bar given, to intervene at this point. And the final point I will make, however, is heart failure is of central importance here. Although subclinical atrial fibrillation is a very good predictor of stroke, about a 2.5-fold increase in the relative risk for short-lasting subclinical AF, it's somewhere between a 4- and 5-fold increase in the risk of heart failure hospitalization and heart failure death. So, even though we're speaking to largely a stroke group, it is important that we consider the heart failure angle. So I think for me at this point, this is still a little early in this patient, but as Andrea alludes to, this is a moving target.
So do we have a comment from the anyone? So
Let me-
my opinion, sorry.
No, please, Jan, go ahead. Go ahead.
Okay. My opinion is we do need more evidence on this. We unfortunately, we do not have enough data for these kind of cases. But however, I happen to have such a case a couple of weeks ago. Patient himself is a famous doctor at his 60, come with asymptomatic AF, but if we checked, it has a preserved heart failure, but NT-proBNP is around 1,000. So the patient claims he is asymptomatic. So we plan to give him ablation. However, one of my colleagues says the heart rate is normal, about only 60 averagely. So he believes there is no need for ablation. Instead, may increase the risk for a tachycardia or whatever. And we decided to give him a cardioversion and plus amiodarone. So a few weeks later, the BNP totally normal. More importantly is patients say he feels much better than before. So the asymptomatic AF is not really asymptomatic. Just he got used to that. Once he got the sinus rhythm restored, he feels much better than before. I think that's a good example. Also, I think last month maybe, data from Japan, a registration from multiple Japanese hospital reported probably 80 cases for such a case. And it also suggests we should try to ablate or convert HFib to sinus rhythm. Thank you.
I think that's actually such a great point to bring people back to sinus rhythm. Sometimes they don't think they're symptomatic until they're feeling better in sinus.
Yeah, no, I mean, again, not apropos of our particular case here, but I support that as well. I think most people I see with persistent HFib first diagnosis get a trial of sinus rhythm, to see if they feel better when they go back to sinus rhythm, but even more importantly or tellingly, to see if they actually feel anything when they go back into atrial fibrillation, if they recur.
Oscar.
Yeah, let me make a quick question for both of you guys. You consider that these permanent atrial fibrillations are really important, but my question is regarding the runs, the short runs. How long should be a run of atrial fibrillation during monitoring a patient to be considered a real great risk, or every time we detect runs independently of the duration of the run, we should consider them as atrial fibrillation to be protected?
So maybe I can take an initial bite out of this one. First of all, I think is a definitional thing. I am not willing to call anything less than 30 seconds atrial fibrillation just as a definition, which we've had for some time. And I think the second part of my answer is the duration that means significance depends on how long you monitor. So if you do an ECG for 12 seconds and there's AFib, that means something. If you have a pacemaker in someone for 10 years and you find 12 seconds of AFib, that means something different. And I think the more we learn, there is a dose dependency with atrial fibrillation burden that goes all the way from PACs on one end, but we even measure independent incremental absolute stroke risk when you go from paroxysmal to persistent to permanent atrial fibrillation. There's still progression of risk there. It's about a twofold difference between paroxysmal and permanent AFib, even after adjustment for age and all the stroke risk factors. In the subclinical arena, which is where you're pointing us, the observational data suggests that there is a dose dependency. Ty Glotzer's paper suggested somewhere over 5.5 hour burden. Isabel Van Gelder's paper suggested continuous episodes of greater than 24 hours. Those are rough estimates with continuous monitoring. So that's monitoring with a pacemaker, an ICD, or an implantable monitor. I think the clinical trials that will come out will shed some light on this, right? So we'll see what the effect in NOAA AF is in a few weeks, right, at ESC, and we'll see if there's any benefit to treatment. But both NOAA and Artesia, which we hope to see later in the year, will have all this data on burden. And one good thing that Paulus and I and others have agreed to is do patient level meta-analysis of these two trials together, so you can have hundreds of stroke events where you can really tease out where any benefit might lie. So, but I think, on continuous monitoring of the pacemaker, somewhere between 6 and 24 hours is kind of the best guess at the moment. And when you translate this into shorter monitors like Holters and stuff like that, the duration gets smaller. It's, in the 5 or 6 minutes, but that's, my read. Maybe Andrea, give your impression.
Yeah, no, I agree, Jeff. And I actually, when I think about it, and patients ask you this when you're talking about, rhythm control and bringing them in for cardioversion, or bringing, if that's a really obviously a sustained long amount of AFib. But I'm not so sure, and I'm hoping that you'll be able to tell us with Artesia, we'll hear more with NOAA, is the anticoagulation issue and stroke risk. Is that completely separate? That duration of AFib for a stroke risk may be very different, between that 6 hours and 24 hours. That would be my guess. Now that we're not enrolling in Artesia, is where I say, well, I better put them on anticoagulation until I know the answer, maybe. But in terms of the risk of developing a tachycardia-induced cardiomyopathy, if they're not having symptoms during their AFib, their rates are controlled. How much do I have to worry, or post, drug therapy or post ablation? If they have less than 1% AFib, I'm not going to do something different. But if they're having, is it 5%? Is it 10%? When do I start to see the risk for atrial remodeling or ventricular remodeling and the chance for heart failure? And I don't know that exact percentage. I know we had some data in very young children and SVT and tachycardia-induced cardiomyopathy. That's a very high percentage, but is it the same for AFib? That's rate controlled. I don't know.
I actually think it's great that you bring up both of you bring up a couple of very important points. There are unknowns and there are unknown unknowns. And clearly we need more studies, addressing some of these unknowns to figure out how we better manage patients. But I think this discussion, is very, very helpful. And I think future studies will hopefully give us more information. I think a second thing that came out of it that I think is very important is, both of you had said, and I concur with you, giving a patient a trial of atrial fibrillation restoration to sinus rhythm is key. Some patients, who don't have any LV systolic dysfunction or don't have symptoms and have good rate control, maybe they are symptomatic, maybe they're not, maybe mild LV dysfunction will improve. But I think that trial is important. What I think we need to be careful about is many times clinicians will say, oh, I'm not going to bother trying, and then we don't even know where we stand. Or there's the other end of the bell-shaped curve where they put them on a drug and they're on a drug forever, whether there's significant clinical benefit or not. So I'd like to kind of ask where you guys might have additional maybe alignment. One of the concerns I have with devices and checking are the false positives that can occur, because of far field oversensing or because of, a noise or artifact that is detected. And also whether there's a difference between between atrial fib, atrial flutter, and atrial tachycardia depending on how the devices are set. And some of those things are more problematic with loop recorders or with single chamber devices where it's a little bit more difficult to discern exactly what's going on. So I think sometimes clinicians either don't pay attention to it or they sometimes just go by what the report is. But I think it's very important to have electrogram review. And sometimes we don't know, we're uncertain. But I think that is a problem that sometimes manifests. What do you both think about that? Do you think that is a concern clinically, or do you think I'm over emphasizing that?
I mean, I could start with that. You know, I think you're right. And I think you bring up a really important point about looking at the electrograms. Now for, you know, for AFib, if you see something that with the atrial rates that are over, 300 or really rapid rates, but you need to look at the electrograms. That's really, I feel much more comfortable with that. We see the same thing with, consumer devices, right? You can get some false positives. So I always want to see some kind of signal to show, yes, it's AFib, but a flutter is also, the really, similar risk, or is at least included in the risk. I tend to be, pretty conservative with anticoagulation. Someone who's had clinical AFib, it's been long episodes, even if they have an ablation and we think they're in sinus rhythm. I don't think we have data yet, based on our guidelines would tell us based on other, risk factors like using the CHA2DS2-VASc score, if they had if they have an indication to anticoagulate before ablation, even if you think you're doing a great job and you don't think they're having any AFib, I continue anticoagulation, even if they've been monitored frequently within the first couple of years. They could have, we know people can recover after even an AFib ablation. So I take that anticoagulation issue right now very separate from what to do in terms of rhythm control, but looking at electrograms, looking at your tracings is really important.
I agree with that. I mean, we certainly did in the early subclinical AF trials see many false positives. So I think it is important. There are gains being made, though, in the consumer space with the AIs for the wearables and the cell phone based apps, and they have had a major impact on reducing false positives. So, we have some competition in the interpreting electrogram department, which is, as always, healthy competition. In terms of the flutter fib debate, I can speak to what I know from our pacemaker and ICD studies, is that when one looks at a right atrial electrogram, which of course is not an ECG, we didn't see any difference in the stroke rate between organized right atrial electrograms and disorganized. It obviously depends on, the bipole spacing of that leads, where you put it, if it's on the septum, if it's on the free. There's a whole bunch of factors that are baked into that, but we could not measure any difference in the stroke risk depending on. It was split roughly into thirds. Interesting enough, a third were highly organized, a third were highly disorganized, and a third were somewhere in between. And it really didn't impact the stroke rate.
Well, thank you both very much for addressing this, particular topic that is, the role of trying to maintain sinus rhythm in subclinical atrial fibrillation. Let's go on to the second case, which puts front and center the role of, thromboembolic risk reduction. So the second case is that of a 72-year-old gentleman who has mild palpitations and does have an Apple Watch, maybe with great AI, Jeff, so that they're better than electrophysiologists in interpretation. But anyway, this particular gentleman has a CHA2DS2-VASc score of 2, secondary to his age of 72 years and controlled hypertension. His Apple Watch has shown short bursts of atrial fibrillation, and by the patient's best guess, looking at all the tracings, they typically last anywhere from 30 minutes to up to 8 hours and approximately 2 or 3 times a month. But he did have one recent spell that lasted about 2 days. Rate was controlled during it. So the debate, I guess, here is, would you use anticoagulant therapy in this patient or would you not? Andrea, we'll let you start it off by taking the approach that you recommend oral anticoagulation in this patient.
Okay, great. Thank you. So I definitely would recommend anticoagulation in this patient for a few reasons. So we know that we can prevent strokes with anticoagulation. We have lots of nice studies, showing that. And a lot of these strokes are maybe due to AFib, about a third or so. They're worse strokes if you have AFib and they have greater disability than if they're non-AFib strokes. But the risk of stroke is not homogeneous, and it depends on additional risk factors. And it's, we know that the ones that are in the CHA2DS2-VASc score, and this is in our guidelines, guidelines, in the US guidelines, as well as European guidelines. If you have a CHA2DS2-VASc score of 2 or greater in men or 3 or greater in women, we do anticoagulate based on the stroke risk. Now, there are many other factors that are not in that CHA2DS2-VASc score, right? It's just an easy score and an easy way to count 1 + 1 + 2. AFib burden is a really important one of those many factors. And, we talk about clinical AFib, but really that's just the tip of the iceberg, right? We know that we've been talking about device detected AFib. Now we have consumer devices. And so, the guidelines from ESC have defined subclinical AFib without symptoms. Clinical AFib is not previously detected on an ECG, and you detect this either by an implantable monitor or a wearable monitor. And it does say in this guideline, confirmed by visual view. So I'm going to just point out, that this patient had some symptoms. So I'm not so sure he's subclinical, because if someone has symptoms, we go and we try to get monitoring. And if you have an episode that lasts over 2 days, I think we'll see in some data Jeff alluded to already, the over 24-hour point. So this person, there's no question in my mind that we would anticoagulate. However, let's just make them a little more clearly subclinical, cross off the palpitations and cross off the duration, and make them all maybe about 8 hours, up to 8 hours. So we have lots of ways to monitor these patients, and we have most of the stroke risk data, much of which Dr. Healey has given us, is from implantable devices. So we know that a lot of patients can have AFib. They have devices implanted for other reasons, pacemakers or ICDs, never had AFib. A lot of them can develop AFib during follow-up. And how you define it, assert, greater than 6 minutes, and that's in the range of most of the studies. There's different patterns, and I don't think we know a lot about this yet. You have these little bursts of AFib, and you could have more longer duration, and you could have these little bursts intermittently and nothing in between. Now, if you look at, these are patients who, looking at people who had clinical AFib and this paroxysmal AFib, looking at people not on anticoagulation, if they divided it up into tertiles, and if you were in that upper tertile, 11% or more burden of AFib, off anticoagulation, the stroke risk was, pretty significant there. And that is even after taking into account other risk scores, including CHA2DS2-VASc score. We know there is an association between subclinical AFib and clinical AFib. You're about 5.7-fold more likely to have clinical AFib. And a meta-analysis looking at the risk of stroke in subclinical AFib, you could see that it is associated with an elevated risk of stroke, but this risk is lower than that described for clinical AFib. Dr. Healey's study ASSERT was a great study looking at ages 65 or older hypertension patients had a recent device implanted, and looking at the presence of subclinical atrial arrhythmias, you could see the risk of stroke is higher. This is blown up here on the y-axis than those who do not have subclinical AFib. And at that point, it was CHA2DS2 score. With subclinical AFib, it was about 1.3% per year. Without was less than 1%, 0.7% per year. And now this is what Dr. Healey was alluding to before, is an analysis of the duration of AFib in ASSERT. And you could see here, if your duration of subclinical AFib was greater than 24 hours, our case did put that 2-day episode in there, the risk is much higher compared to those who had shorter duration, between minutes and less than 24 hours, no difference than when you compare it to those who did not have subclinical AFib. So these patients definitely need anticoagulation. Now, you can argue a little bit. The loop study is a little bit of, I think, a surprise for some people. This is looking at implantable loops in patients who are 70 to 90. Denmark is where it was done, and they had at least one additional risk factor, and they were randomized to loop monitors versus usual care. Anticoagulation was recommended if they had just 6 minutes detected. Now, no surprise, but with an implantable loop, your 32% had AFib detected compared to 12%, 12% being higher in the control group than one would imagine would have been compared to other studies. And anticoagulation, no surprise, was initiated more often in the loop group than in the usual care group. However, the primary outcome in this trial was time to stroke or systemic embolism was not significantly different. If, the p-value here is, You could say, well, maybe we're getting there. If we followed these patients longer, you could see these curves continue to separate. And I would question whether longer follow-up would have seen a difference. But if you look at the group who had loops, and again, no surprise, you're detecting AFib that's probably of shorter duration than you would see in someone who has usual care. And the median burden was only 0.13%, very little AFib, and only 5.6% had a duration of 24 hours or more. Now, Artesia, we're all anxiously awaiting the results of this study that was run by Dr. Healey. You had to have 6 minutes or more, no episodes over 24 hours. So conceding to those patients probably do need anticoagulation, randomizing apixaban to just aspirin. Well, NOAA was another study, edoxaban versus aspirin. I do not know any of those results. Hopefully we will see them shortly. Although it has been said, perhaps that was stopped due to futility. We do have other devices just to mention, as in this case, you could detect these on consumer devices. Either these wearable devices could be PPG-based, photoplethysmography, or ECG-based. And some of the devices, like the Apple Watch here, has a blended technology. Here, you're just getting some intermittent recordings. You can get false positives. You need to look out for that. The Apple Watch and the Fitbit use different algorithms and tachograms, so you can detect if you meet those criteria, trying not to get too many false positives. It doesn't mean you don't have AFib if you don't get an alert, but it's trying to reduce false positives. So, there is this interaction between stroke risk factors and AFib burden. We know that atrial arrhythmias are common in patients with implanted devices, as well as now we see them on consumer devices. We know that the subclinical atrial arrhythmias increase the risk for thromboembolic events, but that's probably appears to be lower than those who have clinical AFib. Maybe that's a duration issue, a burden issue. Studies have correlated thromboembolic risk with the duration of these episodes, particularly if it's over 24 hours. Those are really high risk based on a CERT. And so we don't really know what to do with everyone else who's less than 24 hours right now. But I would say until we have the results of the other 2 randomized trials, that I would say if right now, if I have a patient who has multiple risk factors, I can't enroll them in Artesia because the studies in follow-up. I would anticoagulate someone between short duration, maybe not 6 minutes, but somewhere less than 24 hours. I would anticoagulate with multiple risk factors using whatever we can do in a shared decision-making approach. Thank you.
Thanks, Andrea. Okay, Jeff, it's up to you now to present your thoughts.
Good. Well, again, I'm going to put a counterpoint to this, and we're going to focus on a few things. First of all, this is a patient who's diagnosed themselves with atrial fibrillation using a smartwatch, essentially in an AF screening way. Like he has undertaken his own atrial fibrillation screening program. And the first point I'll make is this is not something that, at least in the United States, is currently endorsed by the screening agencies, the USPSTF, and we'll show some data on this. Second is that if we screen older people or people with cardiovascular risk factors, we're going to find an awful lot of atrial fibrillation. And just because we find it doesn't mean it necessarily means treatment. And I'm going to steer off the 2-day episode as well for the sake of a good debate. We also have to consider false positives. This is a watch. What's the risk there? Next, we have to consider that atrial fibrillation detected in this way is likely much lower burden than what we see in observational studies like Framingham. And I'll bend your mind a little bit by showing you that everything we know about anticoagulation in atrial fibrillation is largely based in people with very, very high burden atrial fibrillation. And I'll hold a little surprise just to see how high burden, but we forget that we largely have studied anticoagulants in patients with extremely high burden and not an even moderate burden of this. And then finally, the NOAA AF trial, as Andrea says, the rumor has it that it's stopped for futility. No results known to me either. So that does raise the suspicion that, hey, maybe this is not an automatic that all patients with short-lasting atrial fibrillation should be treated. So there's the guideline from the USPSTF, currently giving screening for atrial fibrillation in patients over 50 an incomplete rating, meaning they neither endorse it nor speak against the practice of screening for atrial fibrillation, despite the fact that we have many great technologies that can diagnose atrial fibrillation. And part of the issue here is this is a big issue. If you use various cutoffs here, and this is with an implantable loop recorder study called ASSERT-2, many years old now, but you can see in a over 65 population with typical cardiovascular risk factors, if you monitor for even 1 to 1.5 years, you're going to find an awful lot of atrial fibrillation, somewhere around a third of individuals with episodes greater than 5 minutes at 1 year. And these individuals, when you diagnose very infrequent low burden atrial fibrillation, as Dr. Russo has mentioned, their risk of stroke is not negligible, but it is small in comparison here with a 1.7% annual risk if you had subclinical atrial fibrillation detected. Now, being a stroke crowd, we've looked at this in the past, right? We had Crystal AF, we put loop recorders in people, 1/3 had subclinical atrial fibrillation. We said, aha, let's treat these individuals and we can prevent stroke. The reality is we've had 2 large clinical trials. This is Navigate-ESUS, also Respect-ESUS, comparing aspirin with an anticoagulant in people with embolic looking stroke. So if you think this group of people has a low risk, the highest risk group you're going to find is patients who've just suffered an embolic looking stroke. And here we did not move the needle with empiric therapy. And people argue, well, only 1/3 of those individuals had atrial fibrillation. Next comes Arcadia. They boil this population down and say, okay, you have to have an embolic stroke, but you have to have a big left atrium or high natriuretic peptides. And again, the presentation was that there was no effect, no reduction in stroke using an anticoagulant compared to aspirin. So, 2 strikes here with this approach. And part of the explanation may be the burden explanation, just the absolute risk is lower. These are the data I alluded to before. If you look in black, paroxysmal atrial fibrillation has only about half the risk of stroke of patients in permanent atrial fibrillation, and these are aspirin-treated patients who have been adjusted for all other stroke risk factors. So burden is important, and perhaps this is why there was no effect in those post-stroke trials. And here, these are just the data on the recent DOAC trials, but they're more or less the same when one looks at the original warfarin trials. Somewhere between 70 and 85% of those patients in those trials were in persistent or permanent atrial fibrillation. So extremely high burden. And, Andrea may be too young, but John and Oscar and I are not, that remember enrolling patients in some of the warfarin trials and some of these trials. And if you had paroxysmal AFib, you had to have 3 12-lead ECGs in the preceding 6 months to be qualified. And so again, even paroxysmal was very high burden. So, what bends your mind a little bit when you think about it is most of what we know about anticoagulation for atrial fibrillation is based on patients with exceedingly high burden. And we're only now getting to the clinical trials at the other end of the spectrum where patients have very low burden. This is the NOAA result, which was presented in a few weeks at the ESC by Paulus Kirchhoff. And so we will soon know what happens at the low end with anticoagulation. Professor Russo has shown these trials, the stroke stop and the screen AF trial. These are screening trials, very large numbers of patients, 6 and 28,000 patients. And they come close to showing a reduction here in stroke when you look at it on treatment or per protocol analysis rather. But overall in the intention to treat, looking at their primary outcomes, they're very borderline. So again, you can see why the USPSTF takes this very cautious approach to screening, because it's so common. The potential to affect the lives of people, many Americans in this case, positively or negatively, is quite high, right? And we still, are looking for more data. Jonathan Mant in the UK group was SAFER. I mean, you want to see a clinical trial of size, 126,000 patients randomized. That's a pretty big trial, even by our Hamilton standards. And so we, anxiously await that plus a meta-analysis. And then finally, the issue of false positives. So Again, the longer the episode, the lower likelihood there is to be a false positive. That I think is fairly accepted. The data from the Apple Heart study itself were that 1/3 had AFib detected on a subsequent patch not done at the same time, but when patches and watches were measured at the same time, about 84% were concordant. So with the prior generation of this Apple Watch, these were the types of false positives, if you will, or failed detects that you had. So I think, again, we should take a cautious approach. I'll make this honest, and I'll throw out the 2-day episode as well, because I think that crosses my own personal line in the sand right now when we wait for data. That could change, right? If the results of NOAA and Artesia are completely neutral, even for the longer episodes, then we might have to think about that group in the middle. But I think for now, my reticence here for treatment is that this is a super common, like we could be treating tens of millions of North Americans here if we went out and screened and found this stuff. So I think that's the bottom line here. I think we'll know more when we see NOAA and Artesia. And this, in terms of screening in the general population, again, we're on a good path to clinical trial data here, but I think we're still 2 to 4 years away from having clear results. So thank you.
Thanks, Jeff, for that very nice presentation. So we're going to get to the rebuttal. So Andrea, first of all, Jeff praised you by calling you a young woman. So now you can see if he's an old fart and rebut some of the comments that he made. He made a very strong case for, holding off and being cautious and, waiting until we have more data. So let's see how you would retort to his, conservative approach.
Right. No, I do. I thank you for that comment. I'm not so sure that is truly the case, but anyway,
it's a debate.
Thank you for that. It's a debate. So I do agree, and I'm certainly very bothered with this population, not just in terms of of the anticoagulation issue is what we're talking about now, but people get down this pathway. They find something on their watch, they may or may not have other monitors done, and all of a sudden they get an ablation. And so I think there's we need to kind of temper some of this, and then I also ask myself too, is some of this going to change if we have anticoagulants like the factor 11A inhibitors that might be lower risk of bleeding? So then if we kind of change that scale and the risk benefit, might we be needing to kind of look at some of this again? But I do do have concerns there. And I always never like these either, but people making these kind of tables, looking at the red area, kind of implying we should anticoagulate these. But just the point of this is there are other factors, right? It's just not only the duration, but it's all the other things too. And even people with clinical AFib, we know that each of those 1 points in the CHA2DS2-VASc score may not all be equal, right? If you're 68, maybe that's a little higher risk than if you have a CHA2DS2-VASc, a 1 point from something else, and that's a more continuous risk as we get older. So I do think there's so much uncertainty here. And then on top of that, this is just looking at device detected AF, but now we have, all these other devices. They do have AI. That's fortunate that maybe we are able to detect that. And there's a whole bunch of studies, looking at the detection of AF and thromboembolic risk. And this one is kind of has two different pieces of it. One of the large, with looking at thousands and thousands of patients with our digital health studies, is one advantage. When we did with the Apple Heart study, we were able to get some information, but a very low detection in that screening population. And I guess that is what we're talking about here too. So part of this in this study will also be looking at what the outcome is in this Apple Watch detected AFib, and then I guess we'll get more answers to this as time goes on with more studies.
I think it's a good slide, your previous slide with the grid, to exemplify a certain point. I mean, those slides put the red zone at 1% per year. That's when you should be pulling the trigger on anticoagulation. The interesting fact is, if you look in all the DOAC trials, the 10A and the direct thrombin inhibitor trials, and you look at the DOAC arm of those trials, and these are clinical trials, the best patients, the best study teams looking after them. In the anticoagulation arm, their stroke risk is 1% per year on treatment. And they tend to be, perhaps a decade younger than the patients we're seeing in the pacemaker ICD trials, who are typically older. And so the question really becomes not what is the risk of stroke, but really what is the risk of stroke that you can eliminate through anticoagulation? Because it could be that of those 1.38% per year strokes in some of those older patient groups, none of it may be preventable. These might be all, different things, lacunar infarcts, atheroemboli, bleeds, these sorts of things. And so that's where I think we're really going to learn a lot in the coming days. And as you rightfully point out, Andrea, this is all a balance of risk and benefit, right? So, when you're dealing with subclinical atrial fibrillation, as many groups have shown, the stroke severity, if you use modified Rankin score, for example, is not what we see in clinical AF trials. We don't have these, 1/3 fatal and 1/3 severely disabling Rankin, 5 and 6 type strokes. We see much smaller strokes. So again, when you're weighing a stroke with a modified Rankin of 2 against a life-threatening bleed resulting in surgery and transfusion, which is the worst event? I think it's no longer axiomatic that stroke is always worse than bleeds, because sometimes it goes the other way. But again, huge supporter of clinical trials. Great to see that many are being done, and great to have these debates with colleagues who know the field very well and can tease out the areas where we don't know, but who are not also afraid to say what they would do in the meantime, because of course we all operate in the world pending clinical trials. So I think these debates I find extremely enlivening.
And Jeff, it was also the first time I read your CERT trial, I remember thinking, in the group that had subclinical AFib as an overall group, it was like 1.29% per year. I think it was the number of the risk of stroke with a CHADS 2 score of 2, I think it was, or something. So, but if you look at what our guidelines say, right? If you're a 1, I think that risk is about 1.3% per year. So I'm thinking not everyone anticoagulates at CHADS VASC of 1. So should we be anticoagulating all those patients? So, so I don't know what your thoughts are, about that, or I guess, kind of getting down into the weeds and trying to look at the different groups. It's not just everyone. It's probably a big part of duration of AFib, but it's all these other factors I think about too, that increased risk of stroke that we really never talk about, right? They're not in CHADS VASC, renal dysfunction, all these other things, left atrial, huge atrium and scarring and all these other kind of things we think may contribute. I don't know.
Yeah, no, I think we're going to have a good 2 years of discussions, debates at meetings, sub-studies. I think a lot has come together. I mean, I would have thought that, Navigate ESUS and Respect ESUS would have been a slam dunk, that would have just, a third of these patients have AFib, they just had a big stroke, just treat them up and they should do fine. And 0 for 2. And then Arcadia said, okay, listen, a third aren't going to have it in Arcadia. Half the patients, if you look, are going to have subclinical AFib if they have these big atria and things like this. And again, completely neutral trial on the efficacy side. So, I think this is exciting, but we have to regroup, and we'll, just like everything in the science of medicine, we'll figure out this era, and then, as you say, something might turn up, one of the factor 11s or many of the factor 11s may hit, and now we have a even safer antithrombotic agent that might have benefit, and then the calculus has to be redone.
Excellent points that you both make. Does anyone have a question that they would like to pose briefly to Jeff or to Andrea? Oscar, we're coming close to the top of the hour, so go ahead.
Yeah, I want to thank you because you remarked 3 things that are important: the age of the patient, the real insurance that anticoagulants remark, and the psychological aspect of wearing a smartwatch. That's important to remark because patients think that they are safer when they have a smartwatch and they control their rhythm. 2 things I want to make because you said about the false positive aspects of smartwatches. And I want to ask you, how important is atrial tachycardia detected by these watches? Many times it is an equivalent to atrial fibrillation, or we should make a difference and start to make any remarks on what's the difference?
Yeah, so sometimes you bring up a good point. I mean, sometimes when I'm looking at the patients bring them to the office all the time, right? And so you're trying to decide what the exact rhythm is, and it is mostly regular, and is it flutter, is it atrial tach, and what's the atrial rate, and what atrial rate. We know the flutter rate is as Jeff pointed out too, is when you look at a single lead, and depending on where that lead is, it might be on the other side of the crista terminalis, and you may not get what looks like AFib, and it may be AFib in the rest of the heart. And we've seen in EP studies, right, that it may be AFib. So I have a hard time, and I think your point is well taken, is differentiating sometimes on these strips on a single lead, what is a atrial tach, what's a flutter, but it's a good point and sometimes unclear.
Yeah, absolutely. Completely agree with that. Sometimes we use atrial tachycardia as a generic term for episodes under 30 seconds or not. I typically would call that non-sustained atrial tachycardia, even if it looks a bit irregular, if it only lasts 3 or 4 seconds, just to avoid any influencing decisions. But I also treat them more or less the same. It's more duration based. And they coexist, right? You see atrial flutter today, you see tachycardia tomorrow, and then 3 months later you see atrial fibrillation. So they're often going together.
Well, this has been a great session where there's been, great discussion and debate about controversial topics. Maybe in 15 seconds each, if you could summarize whom you would anticoagulate, what you would do for duration, what you would do for, risk factors like CHA2DS2-VASc and others that you would accumulate. I realize that we don't have definitive data, and like you nicely said, Jeff, based on published studies and, presentations, we will be looking at this over the next few years. But in July of 2023, if you're a clinician watching this session and they ask you, where would you start anticoagulant and where would you hold it? Give us your thoughts, realizing it may and probably will need to change.
Yeah, so right now for me, on a pacemaker, 24 hours, I anticoagulate. If it's a stroke patient, I'll go down to a few hours. If it's a recent stroke, not a lacune 20 years ago, but a recent stroke, ischemic stroke, I'll go down to a couple of hours. On a Holter, an asymptomatic individual, around 5 or 6 minutes on a 48-hour Holter, for example. And again, in the stroke world, it's hard to hold back a stroke neurologist, Oscar, with 30 seconds of AFib post-stroke on a Holter. I've not been ever able to do it. And so those are my lines, but they could be as good or bad as anybody else's.
Agree. And by the way, do you use any other risk factors for the non-stroke patients, like the CHA2DS2-VASc score, or do you use duration alone?
Yeah, sure. I mean, absolutely. I mean, you can have some very high risk individuals without stroke. CHA2DS2-VASc score of 5 or 6 even.
Yeah, so you might play it up and down in duration based on score. Mm-hmm. Andrea, do you want to finish up?
Very similar, over 24 hours for sure, and within that 24-hour mark, and then less than that, based on other risk factors, and looking at which if they're 69 or 72, I get more worried with the age and the history of stroke risk factors, stroke or TIA, if it's definitive TIA. But looking at CHA2DS2-VASc score, shorter duration, I have a hard time within minutes of AFib, but within several hours, 5.5 hours, 6 hours, somewhere around there, until we have more data if they have a very high CHA2DS2-VASc score or history of stroke.
Great. Well, again, thank you both very much for your excellent presentations and for your, sharing of your concepts and your thoughts. And Jeff, thank you for, being a leader in this field and driving research trials to allow us to have better information to better take care of patients. With that, I'm going to turn it back to you, Oscar, to close out.
Okay. Again, thanks to all of you, really, Andrea and Jeff, for the excellent presentations, Yao and Tommy for taking care of the coordination, and all the different regional societies that are transmitting our webinar. I hope that very soon we are going to continue having webinars, and really this was an excellent presentation, and really I mean that thanks to all is like nothing, because that was a very, very nice presentation.